So I'm going to talk about this ill-defined entity or becoming more defined of atrial cardiomyopathy and what it means in terms of stroke risk and anticoagulation. And again, I think EHRA has played a leading role in this back 6 years ago with this consensus document laying down some of the definitional matters in terms of what it is. And of course, we see it as a potential cause of some cryptogenic strokes, maybe a therapeutic target for anticoagulation, and at the base of it, a risk factor for atrial fibrillation. And we're talking about structural, hormonal, endothelial changes into the atrium, which may link up to stroke through atrial fibrillation in a way that we understand. They may link up additionally through independent mechanisms that are not dependent on the development of atrial fibrillation. And of course, this is the broad concept that is tried to be encapsulated with this entity. Now, I'll just go back here, and I think I come to it in another slide, but there are many names for this, right? Atrial cardiomyopathy, atrial myopathy, etc. I've tended to net out on the atrial cardiopathy because you really conceive of this as not just a myopathic process, but a disorder of endothelial function, among other things as well. Now, we know structure is related to the risk of developing atrial fibrillation. I think we have the most data for this association. These are the data of Teresa Sang dating back 20 years from Olmsted County around Mayo Clinic, here using atrial volume with echocardiography, and surely you can see the marked increase in the risk of developing clinical atrial fibrillation for those with large left atria. We also talk about stroke risk and what role substrate in terms of the geometric shape of the atrial appendage, for example, has on risk of stroke. And this is obviously more recent work happening in the last 10 years. And then you can look at the heart as not only a structural entity, a mechanical pump, but looking at the hormonal function of the atria and indeed the ventricles, and here with a lot of data around NT-proBNP and atrial fibrillation risk, with risk increasing here in the upper quintile of greater than 290 nanograms per milliliter. So there is a wealth of data looking at the association between various aspects of atrial structure and atrial function, and both the risk of atrial fibrillation and stroke. For those of us involved in the ablation world, some more difficult to measure entities like atrial scar burden, fibrosis, here using MRI is also associated with AFib risk. And so these are the background materials to help to define what this is that we're dealing with. Now, Georg is correct. I think you are the only stroke neurologist in the building, but stroke neurologists have contributed a lot to this way of thinking, and Human Kamel and others in the United States, Mitch Elkind, have looked a lot at population-based data to link other measures of atrial cardiopathy and stroke risk specifically. And these are simple things that you would find in large cohort studies like ECG markers like P-wave terminal force, PAC frequency, and then more simple markers than Teresa Sang used, such as left atrial dimension, diameter, and index diameter. And of course, you can see down the right-hand side that many or most of these do show a positive association, which is significant for the development of stroke. So these are finding use in population, but also in our post-mortem examinations, if you will, of clinical trials. So again, we all know there were two large ESUS trials, RESPECT and NAVIGATE, published. Here are some data we looked at from NAVIGATE, where you took a trial where there was overall no benefit seen in terms of stroke prevention using an anticoagulant compared to an antiplatelet in patients with an ESUS event. But if you confine this to the upper quartile or quintile of LA diameter here at 4.6 centimeters, there does seem to be some indication, albeit hypothesis-generating indication, of a benefit. So, the idea of looking for atrial fibrillation post-ESUS or post-cryptogenic stroke was a start. Then the era of empiric therapy came out. The trials were disappointingly neutral, but the question is here, are there elements within those trials, the patient characteristics, which could identify individuals more likely to benefit? And one of the leading contenders here is left atrial size, again, one of the markers of atrial cardiopathy. So I think someone mentioned it already this morning. The Arcadia trial is ongoing. This is the third of the big ESUS trials, again run by the group in New York City. Patients over 45 years old with a history of ischemic stroke. They are felt to be ESUS, and they have one of three markers of atrial cardiomyopathy, so P-wave terminal force on their ECG, a left atrial size index greater than 3 centimeters per meter squared, or an NT-proBNP close to what that graph showed here, 250 picograms per ml, and they are randomized to an apixaban-based strategy versus aspirin, looking at stroke outcomes, and that trial is ongoing. There are also additional trials looking at other markers here, one pulled off the clinicaltrials.gov website looking at a BNP-guided strategy for post-stroke stratification. So what, I think I'm missing one summary slide here, but what does this mean? What does atrial cardiopathy mean for our practice? I think it really depends on what it will show. And, clearly if there is a marker of atrial cardiopathy which we find useful, for example, post-ESUS, then that will gain traction, and the specific definitions are still up in the air and waiting for something that has meaning. And I think, if Arcadia were to be positive, then obviously those three markers would bubble up and become more popular in terms of how we define this entity, because right now it's a very broadly defined entity, but I think it has use for epidemiology, possibly for atrial fibrillation screening, as was discussed in our last session, and maybe for executing treatment decisions. And for this, I think trials like Arcadia, which embed this concept into their randomized design, will be useful to help move this forward for the next years. So thank you.